Good morning all attendees and panelist team. Today आज हमारा 18वां फ्री वेबिनार का सेशन है जिसका सब्जेक्ट है फंडामेंटल्स ऑफ पेन साइंस मिथ्स एंड एविडेंस ए फिजियोथेरापिस्ट पर्सपेक्टिव और जिसके रिसोर्स पर्सन है जाने माने इंटरनेशनल स्पीकर डॉक्टर मोहम्मद सिद्दीक जो सऊदी अरेबिया से है और सब्जेक्ट के बारे में डॉक्टर मेहुल कॉन्ट्रैक्टर थोड़ा विवरण देंगे। उसके बाद डॉक्टर साहब का परिचय हमारे डॉक्टर नेहा वैद्य देंगे और हम आगे का सेशन शुरू करते हैं। आप सबका हार्दिक स्वागत है। सर प्लीज गिव योर वर्ड्स टू डॉक्टर सिद्दीकी।
Yes. Very good morning to all. See, again we are back on live Facebook. Regarding today's topic, very interesting topic that I would say. Why it is very interesting? You know, if you see 10 cases out of 10, 7 will complain about pain. If you're a clinician, if you're intern, if you're a student practicing in the college right now, or you are a faculty members and seeing a patient in OPD, or if you're on Facebook Live, if the layman person is listening to me and then further he will listen to our speaker. So I want to pass one message that even in a layman persons, in a community, in a society, you may see a lot of patients with pain. But the question to be asked, whether this pain is an actual pain or something else. Need to understand that very clearly. Because until and unless you don't understand the myths and the facts, there is a line in between myths and the facts. Along with the evidence, how will you rule out that this is the line which bifurcate that yes, these are the actual pain and these are the myths. So that is where we need to practice in a right direction, in a right way for a society, for a community to be, to upliftment yourself as well as your, professionals. So the one thing that I would like to say over here is the pain is, itself is in a very broad thing that I would say that pain, based on the one complaint, there are plenty of book has been written. Plenty of books. The other day, Sarvanand sir said that the researches are overloaded right now. Okay, on the Google. The same way the books are overloaded on just one topic, just one complaint, not even topic, complaint. So just guys think how this pain as a complaint when the patient coming to the department, how you need to assess it clinically with evidence-based practice. That is what the topic is all about, and that is what the topic I have brought for all of you. So not wasting much of a time. First of all, I would like to, say thank you so much, Dr. Mohammad Siddiq sir, for requesting my, invitation and sparing your, international time, coordinating with Indian time. And, you are, even though we are apart, but still we are connected. And, still we are looking forward for students. Yes, Facebook Live and all the participants, I would like to tell you that whatever my college, myself, my faculty, my team member, my management, whatever they are doing, they are basically the primary thing that we are focusing on the education. Yes. Okay. Education reach to the people. So, having, distance between, and then still we are making things possible, that's something really great that I would say. And once again, sir, a warm welcome in our team, VN Patel Medical Campus, Shree Odhavram Physiotherapy College. And now, Dr. Neha, over to you. Please warmly welcome, sir. Introduce who is he, okay, so that people, come to know exactly why, he is as a speaker. So over to you.
Thank you so much, Dr. Mehul sir, CEO Prakash sir, and management for giving me this opportunity to introduce the international faculty. Good morning, one and all present over here on this virtual platform. I, Dr. Neha Vaidya, working as Assistant Professor at Shree Odhavram Physiotherapy College. Would like to thank you all for being with us. This is the first time that we are having an international faculty with us as a resource person for the webinar. That is Dr. Mohammad Siddiq sir. Dr. Mohammad Siddiq sir is a senior physiotherapist. Sir has done his bachelor's from Rajiv Gandhi University of Health and Sciences and Masters of Orthopedics from Chaudhry Charan Singh University. Currently, sir is working in Rehabilitation Medicine Department of Ministry of Defense and Aviation, Saudi Arabia. Sir is president and founder of Indian Clinical Research Association, ICRA. Sir is Clinical Research Coordinator at Northern Area Armed Force Hospitals. Sir is International Peer Reviewer at Sultan Qaboos University Medical Journals and International Journal of Creative Research Thoughts. Sir is Institutional Review Board member of Saudi Arabia and is been licensed by National Institute of Health of USA. Sir is an advisor of Medley and elsewhere UK. Sir is been former in-charge physiotherapist at Al Hakim Medical Center, Oman and Sultan Special Forces. Sir is been former department head at Mewars Hospital. Sir has been former lecturer at Srinathji College of Physiotherapy and Institute of Public Health and Hygiene, Delhi. Now, not taking much of time, I would like to invite Dr. Mohammad Siddiq sir to commence the webinar. Sir, over to you. Thank you so much.
Thank you so much, and a very good morning, my dear friends. First of all, I would like to thank the management of Indian Medical Complex and Shree Odhavram College of Physiotherapy, the faculty members of the college, and my dear friend Dr. Mule Contractor, who's been so nice in inviting me to this webinar. And also, I would like to thank all the faculty members, Dr. Mia Vaidya, and all the students. First of all, let me start by this quote. As you have heard that my topic today, when I was discussing Dr. Mule, I thought that let me give them a basic idea and something of that is pain sciences. As you know that pain is real. If a patient or anyone tells you that I have pain, then you should understand that he has pain. And that's what I chose to talk, because this is my area of interest and I've been working on this topic for a long time. So I thought that let me have this kind of topic. So today's topic, as you have already, they have mentioned that it is fundamentals of pain sciences, myths and evidences, a physiotherapist perspective, how we should look at pain and what are the factors and what are the evidences we have that when you are taking a chronic pain. So this is something which I will share, and I hope that if I am taking some time, so I hope that you will be with me some extra 1 hour. So without wasting time, let me start my first slide. So basically, what is pain? As per the International Association of Study for the Study of Pain, they say that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Pain is an emotional experience. Tissue damage is not necessary. This is the crux of the matter. If somebody is telling you that I have pain, that whether there is a tissue injury or not, patient will definitely has pain, and you have to understand that as a clinician, as a researcher, or as any other care provider. If somebody tells you that I have pain, then you should understand that yes, he has pain. It doesn't matter whether there is inflammation, there is tissue injury, or there's anything wrong. But if patient tells you I have pain, if the pain is in psychological pain, in brain, definitely there is pain, because pain has 3 dimensions. Pain cannot be unidimensional. That is the definition of pain. Now, you might have heard about something called as body and brain. Our body, our neurons in our motor cortex, they are grouped by body parts. And together, all the various parts of the body, they form a representative map of the body. It is called as homunculus. If there is something wrong anywhere in the area, from tissues to the brain or any part of the brain, it gets disrupted. There is something called as what I want to show this slide to you. This is called as something called as central sensitization. There's something called as pain catastrophizing or cortical smudging. Now, if you can see in this figure down, you can see this figure. There is something called as smudging. Smudging means there's out of focus. Normally, when you experience any kind of pain, our brain has an area of representation, that is sensory cortex. It will interpret pain, whether it is coming from any part of body, what kind of pain it is coming, whether it is a thumping pain, it is a tingling pain, or it is a excruciating type of pain, or it is something, any kind of pain sensation that is being represented by the brain, and the brain gets an idea that something is wrong with the pain, with the body part. Now, every body part, they represent our area. There is something called as S1 representation. That is when any body part, it has to represent pain, the body part will represent it as a kind of sensation, because brain understands these body parts, not the movements. Now, in the central sensitization, if there is abnormal central brain processing rather than injury to the anatomical area, there is something wrong anywhere in the system, whether it is coming from the tissue where there is injury to the part, or during the pathway of pain, when you have ascending pathway, and when you have thalamus and you have radiations from thalamus to the cortex. If there is something wrong anywhere, patient can have central sensitization. Now, if this pathway gets disrupted in anywhere from the tissue to the brain, there is something called as cortical smudging. Brain becomes out of focus, and he will tell that I have something wrong with it. Now, as a clinician, you have to understand the concept of pain, that pain is not only physical, it can be emotional, it can be social. So there are three dimensions of pain. It cannot be only tissue. Now, when you understand pain sciences, as per Professor Mosley, is a well-known pain scientist from Australia. What he says that if you want to understand pain sciences, for example, if somebody gets hit on a thumb with a hammer, such experiences are easily understood with a structural pathology model. Why? Because you got hit with a hammer on your thumb, there was injury to the thumb and or tissues, and suddenly patient has severe pain. That can be understood with a kind of structural pathology model. Now, which suppose it will provide accurate understanding, indication of the state of tissues. But there are 4 key points. First point is that pain does not provide a measure of the state of tissues. Pain will not tell you in which state of tissues, in which condition they are now, the tissues, when there is hit on the thumb or any part of the body. Second is that pain is modulated by many factors from across the somatic, psychological, and social domain. As I told you that there are 3 dimensions of pain. You cannot only see pain from one spectrum. It has to be understood from the somatic domain, psychological domain, and social domains. That the relationship between pain and state of tissues, it becomes less predictable as pain persists. In chronic pain conditions, what have you seen? We don't know what kind of in which state the tissues are that time when you're chronic pain. So this is the third point which is important as per Professor Mosley. It was very important paper published in 2007 which told us about the understanding pain sciences. Now, fourth is that pain can be conceptualized as a conscious correlate of the implicit perception that tissues is in danger. We can just tell that something is wrong there, but we don't know exactly what is happening. That's what you have to understand, that fundamentals of pain science is that you should understand that normally what we study in our bachelor's or in master's, that we are told that biomechanics is very important part of, yes, it's an important part of your study, but biomechanics cannot tell you exactly what is happening to tissues. For example, a patient comes to you with a low back pain, and therapists, normally what we do in India or what we do anywhere in the part of the world, if a patient starts walking, you tell them please walk. If he walks and if you see slight pronation of the his heel or his calcaneal joint or tendoncular joint, you see any kind of pronation in foot, what we see, we tell him that okay, there is something wrong with the pronation of foot. It can have some kind of dysfunction around the line of gravity or around the length of the leg or whole up, lower limb. Then it can cause problem in the lumbar. So we try to imagine things. But do you have evidence that this amount of pronation can cause problem in the runners? There will be runners injury, or there will be stress on the ACL, or there will be stress on the MCL, or any other ligament. No, we don't have. So you should understand that when you are dealing with any kind of pain subject, you have to understand his whole overall condition, whether patient is psychologically satisfied or he is fit, whether he has any social problems or any somatic problems. This is what, when you understand about the phantom limb pain, there is no limb present, but still patient has pain. So it clearly tells us that pain is not related to the tissue injury or somatic domains. Now, in this era of evidence-based medicine, it's important to question our practice patterns if they have been built on dogma or not evidence. Normally, what happens? What we normally see that we say that we imagine theories, right? But when you are talking about evidence-based practice, you cannot believe on dogmas. You have to understand, you have to show the evidences that these are the evidences available when you are trying to deal with any kind of pain perspective. Now, this is very important that criticizing ourselves is a postulate. Any clinician or even a researcher, if he is not criticizing himself, he cannot be a good researcher, he cannot be a good clinician. So we need to question dogmatic practice patterns to face the challenges we currently have. We owe it to the people under our care to always try to be less wrong, and using research to find the best possible approach to care is a human instinct. It's very important that if you do not question for example, you are using something and you don't know what is happening. So you have to understand that it is very important that you have to break the shallows and stop the conservative dogmatic practice and come into the real research oriented practice that can have an effect on patient care. Now, as I told you, pain is a subjective experience dependent on complex interactions of neurobiological, cognitive, affective, contextual, and environmental factors. Thus, pain management depends on identifying contributing factors from biological, psychological, and contextual domains and addressing them through various evidence-based techniques. So this is very important when you are looking at a pain experiences. You have to understand the whole all dimensions you have taken into consideration without before treating the pain. Now, this is from the Professor Sullivan and Professor Lawrence Emery. They say that the physiotherapy, manual therapy, medical professionals have long focused on trying to find the magic technique. This is called a magic wand. We don't have a magic wand. For example, injections, surgical technique required to solve the problems of non-specific chronic low back pain or pelvic girdle pain. Professor Sullivan tells us that we don't have a magic wand. That हमने कहा कि we have this technique, we use technique, and we are going to have a very good effect or a solution for the pain. No, there is nothing called as magic wand technique or magic technique. No, there's nothing like that. So you have to understand that a multidimensional biopsychosocial framework of the treatment or assessment or planning has to be implemented if you really want to understand the concept of pain and also you want to treat the pain. Now, before, as you understand that we had a biomedical model. Normally, when I was also studying in Karnataka long way in 2001, we understand that it is also called as the apparatus error model, the biomedical model. What is wrong with this model is that all illness and all symptoms and signs arise from underlying abnormality within the body, usually in the functioning or structure of specific organs referred to as disease. If you had any kind of tissue injury or pathology, we used to tell that because of the injury or any kind of illness, patient has pain. But after that, what is the problem with this model that we call it biomedical reasoning? If patient has any abnormality, it can lead to sickness or pain. Now, if you remove this abnormality, there is no sickness, no pain. This is what biomedical model says. But there's a problem. There's a problem that there is lack of scientific based knowledge, there's lack of education about pain, there is lack of critical literacy and lack of comprehensive perspective. These are the things that you have to understand when you want to fundamentally address pain problems. Now, nonetheless, much health and science education and education generally still tend towards rote learning rather than the promotion of critical thinking. Critical thinking is very important, as I told you that a clinician or a researcher, if he is not able to criticize himself that what I'm doing or what I'm assessing pain, am I doing correctly? Do I have the evidence supporting my theories of pain understanding or my treatment protocols? So if he is not criticizing himself, he cannot be a good clinician or a good researcher. That's very important. Now, pain, it exhibits degeneracy by Professor Lars Evermery. Now, we have to understand that there is something called as reductionist approach. That is, complex biological systems, they exhibit degeneracy. That is, an outcome does not have a unique basis and similar patterns of activity can be produced by different mechanisms. We don't know exactly what is happening when you are talking about pain, because pain has multi-dimensional roles and it can vary from culture to culture, ethnicity, population which you are studying, the age group you are studying, the gender differences are there, and the psychological differences are there. So it is a very important complex factor. So pain with same location of the same character may be associated with different cortical activation patterns. You don't know what is happening in brain, so you have to understand that. To understand that, there should be understanding of multi-dimensional patterns of pain, so that we are not losing anything when you are assessing about pain sciences. Now, the neurometrics theory, it guides us away from the Cartesian concept of pain as sensation produced by injury, inflammation, or other tissue pathology, and towards the concept of pain as a multi-dimensional experience produced by multiple influences. So all these papers by Ronald Melzer, they say about that. We have stopped at the biomedical model. Now the onus is on biopsychosocial model of pain. That's very important right now. Now, modern pain management, it should be informed by both qualitative and quantitative research, including research topics like pain experience, what is the experience of pain they are feeling patients, qualitative analysis, this is called as qualitative, then shared decision making. You have to make decisions with different colleagues of yours. You cannot discuss or understand pain singly. You have to take consultation of psychiatrist, a clinical psychologist, a pain physician, and who also working with you. Then pain experience, as I told you that And therapeutic alliance is very important, because pain, when you are talking about pain, you have to work in a multi-dimensional setup, and you have to coordinate with everyone around you who are dealing with pain. It can be anyone part of your team. Single-handedly, you cannot deal pain. That's why pain is multidimensional. And patient empowerment. You have to understand. You have to empower patient. You have to tell him that this is the problem you're getting, and you should not frighten him. You should understand. Tell him that this is the cortical smudging happening. There is something wrong with your catastrophe. You are trying to be hyper vigilant. So there are many things you have to understand regarding when you're talking about pain education. And patient communication. Sometimes patients, when you talk to them nicely, when you have good interaction with them one to one, they tell you that, well, when I'm driving, when I'm alone at my home, I feel more pain. There is something wrong. It's like a social element of the pain. So you have to understand that there should be patient-centered practice, risk factors, hypertrophy, movement variability, and clinical decision making, just to name a few. This, in addition to our research fields like pain sciences, rehabilitation science, exercise science, behavior science, many more. So these are the modern pain management should to see all these factors into qualitative and quantitative approach of pain. Now, indeed, there is also growing evidence that non-specific factors such as therapeutic alliance, patient beliefs and expectations, therapist confidence, pain catastrophizing, self-efficacy are more predictive of clinical outcomes than changes to the target of the therapy. You have to understand that you have to be very good. Therapeutic alliance should be very good. They should patient believe what patient feel, what is his beliefs. You might have seen that in Karnataka, there are some religious people, they wear black dhoti and kurta, and they don't wear chappals or shoes. They walk through the cold and heat time. But when you ask them, do they feel pain? Can you walk? I can't walk. If you tell me to walk barefoot around the hot streets of Gujarat or Karnataka, I can't walk because I get burned. But there are people who barefootly walk on the streets of India, Ayappas, for example, or anyone who are walking Agoris, for example, in Varanasi and UP, they don't feel this pain because they have strong beliefs. They have religious beliefs. So you have, and what are the expectations? Sometimes patient tells you that I have expectation that my pain should be, it should be better, it should be treated nicely. So you have to understand that, and then pain catastrophizing. How much they are catastrophizing pain? Are they exaggerating their pain experiences? So all of this, if a therapist doesn't know what you're going to explain to him, so you have to have a very good understanding of multi-dimensional perspective of pain when you're dealing with any kind of pain, chronic pain, or any kind of management. Now, as there is something called as toolbox-centered care. Now, what happens? This is what I've encountered when I didn't know about pain sciences long back, and Professor Sullivan, Professor Jason tells that toolbox approaches are about the practitioner, not the client or the patient. What happens in this? What is toolbox approach? When you are a therapist in India, whether you are a therapist, you do osteopathy, manipulation, dry needling, cupping, and many other techniques which you do outside the physiotherapy domain. Now, when a patient comes to you, so you think that, okay, he has low back pain, so what should I use? So you take the best technique from your toolbox, right? Okay, I will use osteopathy, or I'll use chiropractic technique. Now, if you fail, what I will do? Where you will go? You have taken the best tool from your store, that is you took technique of HVLA or any technique you took to treat his low back pain. But if you fail, then you randomly go and search, okay, now let me do TENS, let me do IFT, let me give exercises, something like that. So this is called a toolbox approach. It doesn't work in no. So for these toolbox clinicians, they tend to use their favorite tool first. That my tool is cupping, I use cupping first. My tool is dry needling, I use dry needling. My tool is exercise. My tool is any other electromodality. So there is why If they don't get response, they need tools themselves won't get you anywhere. What matters is a reasoning process that underpins it all. You have to have a very good clinical reasoning that why he's having this pain, what are the factors affecting his pain experiences, whether he's having psychological domain, social domain, or somatic domain. So you have to be very clear about that. And then I told you therapeutic alliance is very important. Now, pain management, as per Professor Abemeri, it should accept plausibility, uncertainty, and complexity. If pain management doesn't have these things, then you cannot treat chronic pain conditions. Now, plausibility is an essential and application of existing basic and clinical science to a new hypothesis to give us a new idea of how likely it is to be true. We are not starting from scratch with this question, what would foolishly ignore our over a century of heart. So you have to understand that basic sciences and clinical sciences, you have to make a new hypothesis of pain when you are seeing any patient. If any patient comes to you with pain, you have to think from a broader perspective, that reasoning, what is the evidence I have available, why he's getting this pain. So it cannot be only from the biomechanical aspect of pain. That patient is having kyphotic posture, or there is something wrong, flexion of the spine, thoracic spine. So okay, it is. So we hypothesize things. So it doesn't work like that. Now, pain education is a very important aspect of dealing with but normally we don't use it. So it's very important that the hours of pain education is woefully inadequate given the prevalence of burden of pain. Pain education is very important. I'll show you some study of Professor Lu, how they use pain education to treat pain conditions. Now, we have some issues with this, that a limited understanding of all the relevant physical laws and conditions that apply to a given problem of circumstances. We have to understand that in 20th century, most medical progress resulted from overcoming ignorance. For example, with the introduction of penicillin to treat infection, or the application of intravenous thrombolysis with a recombinant tissue plasminogen activator administered within the 3 hours of cardiovascular accident. In ignorance, that patient, you should not be ignorant. It was before, but in 21st century, we have to stop this kind of practices. Now, therapeutic pain neuroscience education on pain and disability. It's very important that when a patient comes to you, when you assess patient based on his somatic findings or his objective, whatever you assessment you have done, then you want to understand that what is, how, and where you are going to employ this education to the patient when you're treating about the neuroscience education for the patient and pain and disability. Now, this is Professor Lu. What he says is that the more I learn about chronic pain, the more I realize that patients are desperate for help. Healthcare providers have so much to offer, but they don't even know it. This is same with me before, when I had not learned from these great faculties of pain sciences. They say that you don't understand anything about pain. We only know that, okay, here something is wrong, there is some dysfunction of the spine, there is some malalignment, there is some tightness in the tissues, it is causing pain. We make our hypothesis. So that's what. If you don't know properly, how are you going to help patients? So we have to understand that healthcare providers should be very good, they should have very good clinical reasoning when they're going to treat any kind of chronic pain syndromes. Now, this is one of the experiments which was done by Professor Lu and his team. This is a graphic representing how therapeutic neuroscience education can ease pain. See, now in this the picture, you can see there are 3 rows of scan. Now, there was a high-level dancer in America. She had a chronic pain and she was suffering this pain since long time. Now, what they did, now I'll tell you why I'm showing this. See, for example, if a patient comes to you, she tells you or he tells you that, sir, the moment I bend my back, my pain increases. or my pain is worse. Now, as you know that there is something called as kinesiophobia, that is fear of movements. When you are trying to move your back, you tend to believe that during the flexion of my spine, I can have more pain. So you don't bend. And this gets embedded in your brain that no. If I bend forwards, I'll get more pain. So patient doesn't want to bend forwards. So this was experiment was done in the lab of Professor Lu. What they did, you can see in the first row. See, in the first row, this is MRI scan. This high level dancer, she was in the scanner in the first row, relaxing and watching a movie. And these are the dynamic MRI scans. You will notice there are no red blobs. These redness kahin par nahi. You can see that, right? In the second row column, she was asked to move her painful back while she was in a scanner. वो scanner में थी, उनको कहा गया कि just try to bend your back forwards. Now you can see lot of red blobs are there. काफी सारे red dots आ गए हैं scan में. It means that she is having pain, and we can see on the scanner. In third row, last row, Professor Lu took the patient out of the scanner and she was given education about pain sciences, that what is pain catastrophizing, what is sensitization, what is kinesiophobia, everything she was taught about. That doesn't matter if you bend forwards, if there is pain, nothing is going to happen, it will be okay. So after 20-25 minutes, you can see again she was asked to bend her back forwards after giving a very good therapeutic neurosurgeon education. You can see there are only few red blobs. So this has given them a very good understanding of clinical understanding that pain education is very important. When you get a patient, you have to understand why he's getting this pain on bending, whether he's having kinesiophobia or whether he's hypervigilant. So this was a very important paper published in 2014 by Professor Lu. So I just wanted to share with you this. Now, these are the pain pioneers. You might know Professor Mosley, Professor Sullivan, and these are the gems of pain sciences. And when you talk about chronic low back pain and pain sciences, so they have revolutionized the concept of pain in Australia. And I learn a lot from their literature. So I show them in my own slides. Now, Professor Sullivan, they published this paper. This is called as Back Facts, Myths of Chronic Low Back Pain. Now, how many of you know this? I don't know how many of you know this about this paper. This was published by Professor Sullivan. Now, there are 10 points they published in this paper. So this is not 10 points. These are almost 10 papers they have studied. Now, the first point they mentioned that persistent back pain can be scary, but it is rarely dangerous. If a patient comes to you that I have a chronic back pain since 2 years, so you make your own theories. You tell patient, okay, आपको pain है कमर में, okay, आपको ये problem हो गया, आपका tissues में ये हुआ होगा, you have this thing, you have that thing. So you don't know exactly, and you try to frighten him that he can come to you, but you have to tell him that, sir, personal pain can be scary, but it is rarely dangerous. You will not see any patient who is having chronic pain, he dies of chronic pain. No, it's rarely dangerous. Second thing is, getting older is not a cause of back pain. Normally, what we tell that patients, if patient is 60 plus or he comes to you with back pain or any kind of chronic pain, we tell them that, sir, because you are old, you are having osteoporosis, and that's why it is causing a lot of stress on your tissues and this and that, and we make own theories without any evidence. So, getting older is not a cause of pain. You should understand that. We don't have research supporting that. Now, third point is persistent back pain is rarely associated with tissue damage. You should understand that. If patient has chronic low back pain for a long time, it doesn't mean that there is serious tissue damage. Understood? Because the healing of tissues, it occurs within 3 months. So it doesn't matter how long. Might be pain is from psychological domain. You don't know. So that's why I told you that you have to understand pain from a multi-dimensional model of pain. Now, fourth is scans rarely show the cause of low back pain. If anybody will show you MRI scan, normally we see that, okay, oh, show MRI, or you have disc prolapse, or you have this and that. So scans cannot tell you about the cause of pain, because more than 80% of cases which we see, there are non-specific low back pain cases. That means there is no cause. You don't know why, what is the pain. Might be there's combination of factors. So if you also do a scan, might be your disc is more protruded than mine. If you do my scan, there will be one disc. So it doesn't matter. So scans cannot show the cause of back pain. Now, pain with exercises and movement doesn't mean you are doing harm. Now, this is very important for physical therapy point of view. The myth of movements, that if a patient comes to you that, sir, जब मैं ऐसे bend करता हूँ, exercise करता हूँ, मुझे pain होता है, right? I get pain. Now the problem is that when you are not moving your back, for example, see now see my hand. Now this hand, this is our back. Imagine this is our back. Now the moment God has made very flexible our back. You can move anteriorly, posteriorly, sideways, right? Now when you move your back, it easily. Now if you make it your hand rigid and try to bend your back like this, there will be some kind of tissue tensions, or there will be some kind of pain. So if you are trying to increase you're trying to tighten your core, or you're trying to tighten to restrictive tissues, there can be pain on moments. But that is, your tissues are sensitive to movements. So you have to understand, you tell patient that, sir, this is a myth. You cannot, if patient gets pain with exercise and movement, you should tell him, sir, because you have not done exercises properly, or you are not done exercise control. You have, because of fear of pain. That's why this pain is there. But when you are releasing the tension from tissues, or when you are removing the kinesiophobia, you can get well. So this is all the facts I'm sharing with you, not myths. Now, back pain is not caused by poor posture. See how you sit, stand, and do it will not affect your back pain. That is the sixth important point, very important for physiotherapy point of view. There is something called as good and bad posture, but research tells us that there's nothing like that. Yes, might be if you are sitting like this, you might feel fatigue. That's one thing, but it cannot cause back pain by poor posture. Now, back pain is not caused by a weak core. If you have weak abdomen, normally we tell this patient that, sir, because आपका abdominal बड़ा हो चुका है, या men usually pear-shaped abdomen, so you have a weak core, so you can get pain. So I should tell you that patients who have weak core, it is not, there are not many papers supporting this evidence. You have to give me evidence when you are talking about this. If you tell that weak core can cause low back pain, you have to share with me meta-analysis or any systematic use of this, that this can cause. So that is lacking. Now, backers do not wear out every day with loading and bending. Now, this is very important, that if you are trying to lift something, if you are trying to move anywhere, God has made our back very flexible. If God wanted to make it rigid, then it was rigid. But God has made it flexible. So who are we to make it rigid? So that's what, if you are working, if you are doing loading and lifting, anything activity, it doesn't cause any harm to the back. Normally, it facilitates your movement patterns. The ninth point is pain flare-ups. Don't mean that you are damaging yourself. Now, if suddenly there is increase of pain, that means you might have stressed your tissue. You might have given them more stress, or might be there is some kind of inflammation that is causing this pain flare-ups. But it doesn't mean that you are damaging your back. Now, injections, surgery, and strong drugs, opioids, they usually aren't a cure. Now, if a doctor tells you that you need surgery, but we have seen many patients after surgery, they again tell us, sir, I was okay for 6 months, then again my pain started. So there is not a single doctor in the world who can tell that I am there to decrease your pain permanently. Nothing, no. There is always a margin of error. There is always that we don't know that what is the approach you're using, and it's going to help patients. Now, This is the some of the evidences which we are using as a myths. So I'll share with you. There's some papers from Petro evidence, some systematic use and meta-analysis. In Nuri 2019, they published this review that therapeutic ultrasound, there is lack of evidence for the use of ultrasound in low back pain. We don't have evidence. In this evidence, what we saw that ultrasound is, it can decrease pain, but it is more of a placebo effect. We don't have, and 3 studies told that there is no effect at all on chronic low back pain. It is ultrasound. So if anybody tells you that ultrasound is very effective on low back pain, you ask him to give evidence. We don't have. Then Lee 2019, he told kinesiotape. There's a meta-analysis. They showed that pain intensity, there is no significant effect of pain intensity when using K-tape on low back pain. And but there was little the disability was decreased in osteoarthritis disability index when you used kinesiotape. But there's lack of evidence for the use of K-tape when you're treating low back pain. So this is one more myth which are broken. These are the systematic reviews. Then pain neuroscience education, that's called as PNE or TNE. There's a moderate quality evidence to use pain education when you're trying to, because see some patients, they come and when they have a disc prolapse, he is being told that आपका disc बंद हो चुका है, ठीक है, अगर आपने ऐसा bend किया ये और बढ़ेगा. We make theories. Normally physios before also I used to make the theories. आपने bend किया, अगर आपने flexion किया तो disc वापस चला जाएगा पीछे, there will be more pain. But when I understood pain sciences, I don't tell you that. I think patients don't worry. Remove your belt, keep on moving, nothing happens. Because disc after some times it gets shrunk on that area, and healing and natural healing occurs. So it doesn't matter whether he has grade 1 prolapse, grade 2 prolapse, it gets over, and because there is a natural healing process. So if you give him good education, he understands that the fear of movement, kinesiophobia, hypervigilance, that you can very effectively treat when you're using education. Now, TENS. हम में से कितने लोग जो TENS देते हैं? Lot of people might be among you all using TENS for low back pain, but TENS is not recommended to use for chronic low back pain, according to Rosende 2018. This is a meta-analysis. I told you these are all high quality evidence I'm sharing with you, which is to treat low back pain, chronic low back pain. Now, massage, it is not recommended to use for low back pain. Then osteopathy. Osteopathy, जो आजकल इंडिया में ट्रेंड चलता है, that osteopathy can have this kind of effect, but it is not recommended because this lacks evidence. Okay. Next is spinal manipulative therapy, a very important aspect of physiotherapy. यहाँ पर आप देख सकते, there is a moderate quality evidence that we have that. They have shown that it can have very good effect. So I always urge students and faculty or whosoever is working with chronic pain that please have your manual therapy skills. Physiotherapy के अंदर आता है, please have it nicely, because this is the only thing you have. Rather, whether you are doing cupping, dry needling, osteopathy, this is all out of physiotherapy syllabus and domain. These are extra techniques which you are using. But the manual therapy is your technique. If you are very good in that, you can contribute to literature. So this is the analysis done by Rubinstein. Now, there is something called as CBT, cognitive behavioral therapy. There is mixed results in that. Then last is that walking intervention. If they are walking, there is also not more effective in reducing pain and disability. So this is some of the evidence I shared with you to break the myths that what is the most effective. So most effective thing in literature is that's human right now. Now there is something called as failures in 21st century medicine. There is something called as inaptitude. Now it means that knowledge exists, but an individual or group fails to apply the knowledge correctly in a particular circumstances. In rehabilitation, an example of failure due to inaptitude might be clinicians' failure to apply an evidence-based treatment regimen for a subacute low back pain, despite clear and convincing evidence of its efficacy and cost effectiveness. Now, this is very important failure that Normally, we know that we have evidence that this modality is not going to fit on the patient, but due to the patient, we want to use that, or you want to give more time to tell that, sir, I have this special machine, but you don't have the evidence that this machine is effective for this patient. So, as I told you that this is very important that a therapist has to have very understanding of pain sciences, that whether what technique I'm using, is it effective? Do I have the evidence to support? Right? How many of you will be using TENS for chronic low back pain? But as I told you, it is not effective because we don't have evidence of that. So this is a kind of myth. Now, ignorance. A limited understanding of all the relevant physical laws and conditions that apply to a given problem or circumstances. Now, if you are lacking evidence or understanding of the relevant evidences, so still you are using that. So this is ignorance, and this doesn't suit a physical therapy professional. He has to criticize himself. So that was me regarding the a small understanding of pain sciences, and this is what I tell you all, that when you are to understand about pain sciences, you have to know that biopsychosocial model of pain becomes very imperative, that you have to understand that you have to understand biological aspect of pain, psychological and social domains of pain. So that is the a small, because it's a huge topic, so I don't want to bore you all. So I try to be. So I hope that if you have any questions, guys, you are open to ask me.
Yes. Thank you very much, sir.
Yeah.
Yes, it was all based on the evidences, and what all the myths are there, that at least in a short period of time also, but something has been opened up in the brain, that one click, I would say, that should pinch in the brain, that yes, if the patient comes to the department, I need to think different also. Yes, pain is real, but we need to understand what exactly, right? So very informative session, sir. And we all the students, see, I'll tell you something. Whenever you are seeing the case, the sir has explained very nicely. Whenever you are seeing the case of back pain, knee pain, shoulder pain, neck pain, whatsoever it is, okay, first of all, try to take history in depth to rule out the differential diagnosis, and based on that, you try to hunt the evidences. Finally, whatever you make, at least 2 to 3 diagnoses near around the complaints, then you find to hunt the evidences what they have to say over it before going for or before planning for the treatment. Okay, so this is how, if you keep this practicing 1 month, 5 months, 6 months, 8 months, year, 1.5 year, 2 year, 3 years, 3.5 year, 4 years, 5, 6, 7, after so much experience, around at least 5 to 6 years, then you can call, okay, clinically in the area of pain, I sound quite, okay. Okay, I word used okay, not even good, but still okay. Because I mentioned you earlier that the pain, the word itself has a lot of books over it. The research article are overloaded, and you must know that which article is beneficial, because there are so many articles over pain. Which one is good, which one is bad? You should know how to critical appraise that article. Okay, that is especially for PGs and the faculty members, that how to critically appraise the article. But yes, when you specifically for clinicians, they must know the clinical appraisal, which one is good article, which one is bad article, what are the criteria to choose it, and how we should go further. Because as I said, out of 10, you might see 7 cases with the pain. So thank you very much, sir. You have enlightened, wonderfully. in terms of evidence, in terms of myths, in terms of facts, the facts for the back that you shown, the paper was the 10 facts was absolutely, actually I wanted that article also, sir. So if you can send me, I'll circulate among the student
Okay.
and the viewer and the participant also. So thank you very much. So now,
Okay. So anyone they have any doubts they have? Anyone
yes,
has any doubts?
I'm coming to that only, sir. So, Dr. Neha, now over to you. You will look after all the queries of our participants. Yes, please go ahead.
Thank you, sir. There is a question that if person is having core muscle weakness and that is leading to pain, so which protocol we should start with for strengthening of the core muscle?
Okay, weak core muscles, right? Some tissues
Ah,
ultimately cause pain at the time. We with the patient with the strengthening core of muscles, so we put the protocol in that. See, as I told you that our body has a compensating mechanism, right? So as I told you that weak core, if patient has weak core, it doesn't make. See, as I told you that we should not work on assumptions. Now, what we understand. See, if you are thinking on just the biomechanical aspect of pain, you will never be able to understand pain, right? You have to understand this is called as out of box strategy of pain, right? We don't have evidence supporting that weak muscles, abdominal muscles can cause pain, right? So yes, you can understand structural model of pain, but if you really want to address that, you have to, if there is a back pain or there is any kind of spinal pain because of weak abdomen, it is relating. So you have to because we don't have literature supporting that. So you have asked me that it can increase tension over the tissues and ultimately cause pain. Do you have evidence for supporting that? Yes, you have to share with me meta-analysis. See, whatever I showed you papers, they are all federal evidence of 2020, which has clearly shown us that good posture, bad posture cannot influence pain. If you have to see, we can have many theories of pain, but when it comes to meta-analysis, it proves to us that okay, this amount of flexion, if you are doing some amount of flexion, or patient has this kind of abdominal, there is abdominal distension, it can cause pain. You have to view that in research ways. If you don't have evidence, then we cannot tell that this kind of. So normally, what we do, we strengthen. And I've seen maximum people, they go for core strengthening of the back, right? They start exercise strengthening, right? Mainly, normally we see in the patients. But what about the other muscles? There are obliques, there are abdominals, right? There are side flexors, there are rotators. So exercise is very important aspect of pain, because this is a crux of matter, that when you are trying to work with pain or back pain, you have to understand that our God has made our spine very flexible. You cannot restrict movement. So do movement all around. You do flexion, extension. As I told you that there was actually there is video. I couldn't show video. I will show video. There was a study done by Professor Pedro Sullivan in University of Curtin. Patient came. He was having severe pain while bending forwards. But when he was given clear understanding of pain, that pain cannot be caused because of flexion forwards, right? Then he was given a very good education. His kinesiophobia and other events were taken off, and then he was told that no problem. If you feel pain on flexion, it means your tissues are sensitive to pain. But after some time, when there is clear understanding, when you are removing all the phobic factors, he can definitely do wonders. So you can strengthen, yes. Regarding the protocol, which I'm seeing this, that is strengthening core muscles, or what other treatment protocol? Yes. So I told you that regarding protocol, you should have a clear clinical reasoning. It's very important, right? As I told you in between, and therapeutic alliance. You should understand that whether patient is having any structural pathology, whether he's having psychological symptoms, or whether he's having any social problems. Sometimes the patient doesn't have work, he's losing money. So I told you that understanding of pain, you have to understand multi-dimensional issues of pain that can lead to protocol. You don't fit, as I told you, there is a toolbox approach. You cannot fit your best tool to one patient. No, it doesn't work this way. You have to understand that for different patients there is different assessment, different strategy you use. Sometimes patient he'll be having some problem in the brain. So you have to understand, you have to make this clear, and the pain goes off. So it depends on your assessment and clinical reasoning that you can decide your protocol.
Okay. So there is one question regarding that posture. As you have said that the posture is not leading to back pain, same way that it is leading to knee pain also, that abnormal posture will not lead to knee pain.
See, as I told you that back pain, that's why I shared with you this paper from Professor Sulaiman. They clearly tell that a posture cannot cause pain. Might be it can cause it can cause discomfort. If you sit in Indian style toilet for a long time, you know that there is a lot of pressure on the knees, right? That time, or your ankles. If patient is having if he's having osteoarthritic changes, or he's having any very heavyweight person, he's a heavy person, is sitting in this abnormal posture for a long time, it can have pain because you are trying to lower abnormally low tissues. So that can be there. But if you are talking about the poor posture, it cannot cause, it can, as I told you that there is not an evidence that is supporting that. If somebody tells you that a poor posture can cause low back pain, he has to share meta-analysis. Understood? So that is not supporting right now, because there are studies going on, and mainly in University of Curtin, Professor Sulaiman has done a lot of work on this posture, and he told clearly that back pain cannot be caused by poor posture.
Okay. So there is one question from our students that can you please brief the word that pain catastrophizing with example?
Yeah. See, you might have seen patients. If patient comes to you with pain, now for example you are a clinician. If patient comes to you with pain, what we try to do, we try to tell him different stories, theories कि आपको ये हुआ है, इससे ये होगा, and patient tells you a story. See, patient centered is very important. Patient can be malingering, right? He can exaggerate pain experiences. So if somebody is exaggerating pain experiences, आपको उसको stop करना पड़ेगा कि sir, nothing happened. See, now what happens if patient has belief in brain, पेशेंट को बिलीफ है दिमाग में कि अगर मैंने आगे बेंड किया, मैंने बेल्ट नहीं बांधा कमर का, तो मुझे पेन, मेरा डिस्क बढ़ जाएगा, मुझे पेन हो जाएगा, राइट? इफ दिस हैज बिलीफ, नाउ व्हाट इज योर रोल इज टू रिमूव हिज बेल्ट ऑफ, उसको बोलना है बेंड करो. तो उसको नॉर्मली यू नो व्हाट आई डू, if patient came to me with a grade 1 alpha S1 collapse and he was holding back like this, he told me, doctor wallah kathir alam अरबी में मुझे बहुत पेन हो रहा है. तो मैंने उसको कहा कि I showed him one MRI of my other patient that see I have stage 2 this collapse, see I am doing this. Wallah, yes. So you have to remove the fears of the patient. See, if you don't remove the fear from the kinesiophobia of the patient, they have this exaggerated feeling that if I do this will happen. So that is what you have to understand, that उसमें आपको remove करना पड़ेगा वो fear factors. And because kinesiophobias and hypervigilance, it can lead to pain catastrophizing, जहाँ पर patient becomes he exaggerates pain experience, right? Like we see in RSDs. So that is how, when you remove these all factors, you can decrease this kind of exaggeration of pain.
Very good.
And it's very important, Dr. Mule, it's very important when you are if you don't, as I told you in my slide, Professor Lou tells that we have a lot to offer, but we don't know it. हमें पता ही नहीं होता करना क्या है. Clinicians don't know. So we have to understand very importantly, if we don't know about hypervigilance, kinesiophobia, and catastrophizing, what are you going to explain to patients? That is very important when you're dealing with that.
There is a question like the phenomenon is going on in the tradition, that pain and gain phenomenon. So now should we go with that phenomenon? If there is pain, then you will gain the range of motion, or you can gain the strength.
See what I told you in the Dr. Mule is smiling. I think because I showed you facts. I told you the fact is that see, pain is a signal. पेन हम बोलते हैं, जैसे एक इंडिया में एक एड आता है, वो टाइड का एक एड है कि वो दाग अच्छे हैं, ना आपने दाग अच्छे एड आता है ना, हम बोलते हैं पेन अच्छा है. Why? पेन अच्छा क्यों है? Because pain is a signal that something is wrong somewhere. So if pain, अगर pain नहीं होगा तो आपको you don't understand what is the reason for this pain. So pain, if there is a pain, so we have to tell patient, we have to हमें वो search करना पड़ेगा कि ये pain क्यों हो रहा है इसको, whether he is having a physical dimension, psychological or social dimension. So 3 dimensions are very important. Understood? You cannot see pain from a biomechanics point of view. जो हमने पढ़ा था, जो हमने normally physiotherapy जोन पढ़ते हैं बैचलर्स मास्टर्स में, वहाँ पर we used to study that patient is having this dysfunction, तो इससे पेन हो रहा है. But now that has been stopped. Now worldwide आप कहीं भी आप देख लो अमेरिका में, उससे जहाँ पर ये बड़े-बड़े रिसर्च काम करते हैं, they tell us that you should understand pain from the out of box. Not only biomechanics will not teach. So you have to understand that this one pain can be protective. Yes, because of the pain, it is an alarming system. But you should not do this कि आपने पूरा protect कर दिया है. Now patients, who have disc prolapse, उनको ऐसा था कि लाइफ खत्म हो चुकी है. No, there's nothing wrong. Even I had disc prolapse. I tell them that I had disc prolapse, but I was doing very well because I knew that this will shrink after some time. So that is very important, that you have to tell your students and all the, for example, patients, that nothing is going to happen. You can keep on moving, अपना spine move करो आप, but you have to take care that you are not damaging it more. You're not lifting up. बहुत अब patient आपसे बोले सर आपने कहा कि move करो, तो मैंने 50 kg उठा लिया, मुझे acute pain था. No. So that it's very important. As I told you, the pain neurosurgeon education is very important, a part of the strategy when you're dealing.
Pain is good actually, sir, because it acts as a biofeedback for the therapist, clinician. So pain is good actually. It acts as a biofeedback.
That's what I told you that
I was laughing.
Pain, मैं इसलिए कहा ना, I told you that pain अच्छा है. क्यों? That इससे पता है, अगर pain नहीं होगा ना, तो you will not understand your skills. आपको pain से क्या पता चलता है कि आपके skills कहाँ पर है? When you are and tell me if patient, अगर आप patient pain को treat नहीं कर पाए, there is something wrong with you, not with patient. Because हमने समझा ही नहीं है. We don't understand. So we have to understand that clinical vision is very important when you are dealing with the. There's one more question. What is the major factor affecting experience based on advanced? What is this? I didn't understand.
So it is patient, like how to decide the protocol. It should be always experience based or evidence based.
See, I say that it should be a research based and evidence based. Research based होना चाहिए. क्यों? देखिए, जैसे मैंने आपको बताया, अब every patient is a new experience for you. But if you don't have research evidence, for example, I told you, as I told you, Dr. Mule and Dr. Vijay, that osteopathy, we don't have evidence. There's lack of evidence. Only evidence we have, I told you, that is manual therapy. That is it is our crux of physiotherapy. Understood? So always I tell my physiotherapy students and colleagues that you have to improve your skills of manual therapy. Don't go behind. You can learn techniques. See, I'm not against this chiropractors or osteopath or generally, but what I see the trend in India, that they mainly focus on these things. वो अपना भूल जाते हैं कि हम can't do the ground. So that you have to understand. So you have to improve your skills. Manual therapy is very important part of our practice and understanding of pain.
And one more thing that I would like to add over here. See, the question was quite good, that we should rely on experience. Let's consider I'm having 8 years of clinical experience, and particularly I'm dealing with knee, or particularly I'm dealing with shoulder, or particularly I'm dealing with back. So that one case in which the clinician is having an experience of 7 to 8 years in particular area of treating that patient. And the another place, the case number 2, that is evidence-based. So here I would like to add certain things more over that. In that 8 years of clinical experience, while watching or while seeing, while going through the treatment of that particular low back patient or knee patient, you should have done a pilot study over there and create your own outcomes. Okay, your own study will help you for further, to the patient. So yes, we follow the evidence-based practice, but if you are clinician since so long, you are treating your one particular area, then why don't you create your own evidences? Because that will be, you have done your statistics, your data, your way of study. okay, that will be more fruitful than any other else.
I will. Yeah. I want to. I want to add one point to you. As I told you, see, you might have heard that gluteus maximus relation with the low back pain. For example, before when I was studying, I was told that gluteus maximus is the bulkiest muscle of body, largest muscle है, bulkiest muscle है, and if there is something wrong with gluteus maximus, it can cause pain. मेरा अभी मेरा पेपर पब्लिश होने वाला है नेक्स्ट वीक में, कमिंग इन इंटरनेशनल जर्नल ऑफ ऑर्थोपेडिक्स में. हमने स्टडी किया and you know how much years it took me 4 years to complete the study. How many years? 4 years. It is not 1 month or so जैसा होता है. So that study 100 we did the study on 100 soldiers from 25 to 45 years age. उनका गैप था, ठीक है इसमें. Now we found that there is not much relationship because when you are doing the clinical, see, as I told you that clinical practice gives you understanding of some concepts, but when you are doing your research based, so you understand clearly. You have to tell researcher that sir मैंने क्या use किया, whether I use ODI scale, whether I use Roland Morris questionnaire, because आपको पता होगा कि we don't have an object. अभी हमारे पास कोई objective tool नहीं है कि we can measure pain. We can only quantify pain by patient experience. It is subjective. आपको पेशेंट बोलता है सर मुझे ये मॉडरेट पेन है, माइल्ड पेन है, माइल्ड पेशेंट इज लाइंग, यू डोंट नो, बट वी मेनली रिलाई ऑन पेशेंट एक्सपीरियंसेस. बट ऑब्जेक्टिव में अभी हमारे पास ऐसा टूल नहीं आया कि वी कैन टेल ओके एग्जैक्टली आपको इतना पेन है. हमारे पास टूल अभी तक नहीं आया.
It's subjective, right? Yeah. So that is what the sir also said that just to assess one single gluteus maximus he took 5 years. So that 5 years is a duration where he isolatedly tried to understand the gluteus maximus and the correlation of back pain with that associated with the spine, associated with the all lower back pain and the other musculature, right? So what even I said that if we thought of it that I should go with my clinical experience or evidence-based experience, even I would say that you should go with the evidence-based experience. But if you are clinician since long, okay, then you should also do your meta-analysis. You should also do your pilot study. You should also create an outcome measures for your own population in your own setup, so that you can sound quite good, better than others.
There is right? The Dr. Muse, there is one question is asked by Janavi. She has asked a question that what about something about pain adaptation? See, there is something called as if a patient thinks that I have pain, you have to tell the patient why he adapted to pain, because sometimes what happens, he believes that pain is permanent. I cannot get over it. And there are in America, because I had that is my next talk. If that is actually I teach about, that is the rehab. There is something called as pain rehab programs in America right now. It is not, what they do there. They have a 10-point program for the patients who come with chronic pain. मतलब patient बोलता है कि मुझे pain है बहुत सालों, ये ठीक नहीं होगा. They have this belief. So they have made a program where they will, if patients taking opioids or non-narcotic drugs, उनको उससे निकाला जाता है. There is counseling done. There is a pool therapy. There is a yoga therapy. There is meditation. So there are a lot of things are there. So there is a something called as chronic rehabilitation programs in America. So वहाँ पर पेशेंट को भेजते हैं वो, and they assess every aspect of pain. Why he is telling that I have pain, adapted pain. So if, for example, I tell you one story of my friend. He's in Delhi. So Delhi में he is practicing from many years, and he told me, sir, I am a magician. For example, I can treat pain ऐसे मैं कर सकता हूँ, ठीक है. For example, now might be उसने कोई technique use किया. So I told him that there. Give me evidence. I told, okay, very good. I understand you are a very good clinician, but have you published a systematic review or your RCT, something like that? Plus, sir, ये तो नहीं किया. मैंने कहा, then how it is you're telling that you might be there is some other thing which is relieving pain. You don't know. That's why evidence-based practice, research-based practice, it tells you clearly that which factor is affecting pain. As I told you, see how many of you or me we were using TENS for low back pain. How many of you? I think more than 90%. But as I told you that we don't ultrasound. Patient आता है, हम बोलते हैं यार patient को हमें पैसा भी लेना है patient से, so let's take 500 and we will do ultrasound. but you have to understand, आपको पता है कि अल्ट्रासाउंड इफेक्टिव नहीं है, फिर भी आप दे रहे हो. This is what I call ignorance. These are the errors which we are using as clinicians. So हमको देखना पड़ेगा that मसाज कोई रोल नहीं है लो बैक पेन में, टेंस का कोई रोल नहीं है, because it is we don't have evidence. Only evidence is exercises and manual therapy. So a clinician उसके लिए बहुत important बनता है अगर आपके पास evidence है. अगर नहीं पता था, I shared you something. Now your professors are there, students and who are doing सुन रहे हैं, the students, faculty, आपके staff हैं, you can learn more of pain sciences. There is lot of, because ये तो मैंने एक थोड़ा सा crux दिया. To understand this, it takes lot of time. आपको पूरा समझना पड़ेगा models of pain, pathways of pain. अभी जो latest theory बता रही है कि there is no role of pain pathways. That is a different topic. उस पे मेरे सर बात करते हैं, प्रशांत सर. So there is a lot of things are there coming, and there is act therapy, CBT, then a lot of psychological therapies are there which are affecting pain sciences. And अभी आप बताएं मुझे कि PNE के लिए कितना टाइम है. अब इंडिया में ऐसे डॉक्टर्स भी होते हैं जिनके पास टाइम नहीं होता है, वो पेशेंट से बात कहाँ करते हैं, टाइम नहीं होता उनके पास. They only see MRI, okay, and throw it. I have seen that in my experience. मैंने देखा बहुत सारे लोगों को. So that has to, we have to break the crux, and we have to understand that we have to understand pain from the multi-dimensional perspective.
Correct. Is there any other questions and queries, participant?
So there is one patient. So there is one patient, like if patient is having a psychological disturbance, and when we assess the pain intensity, it shows much aggravated. Then how can we differentiate actual intensity from the psychological disturbance? As you have told that there may be a chance of influence of psychology over the pain.
It is very, see, आपने देखा होगा that if patient comes to you with chronic pain syndromes and he is very disturbed, or if he comes to a clinic and you are very nice to him or her and you try to counsel him that nothing is wrong, आपके tissues are absolutely fine, there is nothing wrong, and after some time you see that this is what there is something called as cognitive behavioral therapy, right? Now there is something called as ACT therapy, that is called as, there is ACT therapy which is given for the pain, acceptance and commitment therapy. It's very important therapy of pain sciences. वहाँ पर patient has to accept if something is, pain is there, okay, pain is there, I understand, but what is the things that you should avoid now? Now if patient thinks that doing this can affect me, अब आपने बहुत लोगों को देखा होगा कि I have seen somebody, किसी बाबा ने कहा कि ये पहनने से पेन चला जाएगा, तो they wear this, right? और अंगूठी पहनते हैं, for example, magnetic. Do you have evidence for that? You don't have evidence in that. So you have to break the crux of matter. Patient को बोलना है कि देखो आप अगर आपने bend आगे किया, अगर आपने bend नहीं किया, तो your tissues become insensitive. The moment you bend, there is pain. So you have to remove the kinesiophobia factor. It's very important factor. जैसे मैंने आपसे कहा, hypervigilance. जो patient आपने देखा होगा, there is condition called as RSD, reflex dystrophy, right? उसमें patient, the moment there is Cooley's fracture, after that if it happens, they are very painful, right? And अगर आप उसके बारे में पढ़ोगे, there is nothing wrong in the hand, but it is severely swollen and painful there. What is that? That is hair. Pain is hair. So you have to remove the, उसको बोलते हैं due to kinesiophobia, it leads to hypervigilance and then pain catastrophizing. वो बोलते हैं हमें करना ही नहीं, हमें बहुत severe pain है. So that is very important that when if patient has psychological disturbances, वो आपको counseling is very important. आपको उसको देना पड़ेगा pain education, so that he understands clearly कि मुझे what is wrong where, कहाँ पर क्या, ये हमारा काम होता है. This is your job, my job. That we have to do clinical reasoning and therapeutic alliance. Therapeutic alliance में क्या होता है? अगर आपके पास डॉक्टर है, आपके पास clinical psychologist, उसको वहाँ भेजो. Send him to a clinical psychologist or a psychiatrist. उसकी properly counseling होगी. If he needs some antidepressive drugs or he needs something other counseling, that has to be provided to patient. Because जैसे हम बोलते हैं कि pain is it is multi-dimensional. So you have to use multi-dimensional approach. You cannot use a single approach for every patient. So that is the answer to this question, that counseling is very important.
A simple thing that I will explain in a layman language. A small kid denied to have a cup of milk just because he doesn't like smell or he feel nausea and vomiting. A mother, what does she do? Psychological barrier to break the food. Simple.
Yes.
Simple, right? So this is how, if the patient is coming in the department with psychological barrier and depression, and then along with the chronic pain, we need to counsel first rather than treatment part. The treatment part itself, the primary treatment part itself is in a counsel first. Until and unless you don't counsel, patient is not going to be getting cured. Yes. Any other thing, Dr. Neha?
Yeah, then
Thank you very much, sir. Spending valuable time for us, for our students, viewers, and on behalf of our organizations, I am expressing my gratitude towards you, sir. Thank you a lot, sir.
You're most welcome. You're most welcome.
I wanted to tell you one thing more over here, sir, because there are so many viewers and participants are all from our college, from other colleges also, and the faculty members also. And as far as you are over here, sir, the Dr. Mohammad Sidiqi was about to come in our college at the month of August, upcoming days, but due to this lockdown it couldn't happen. That was the surprise for all, that I didn't share with often. But he was about to come and he was about to join us in the month of August for at least 1 or 2 days, and he wanted to share so many things. So, but due to lockdown, things couldn't happen the way we wanted. He and me both. It couldn't happen in the way the way we wanted. But still, we are hoping that if things get all right, then yes, sir. What do you say?
Yeah, Dr. Mule, thank you. Actually, yeah, one more thing I forgot to tell. Actually, you might be knowing that we have started Indian Clinical Association, right? ICRA, we have started ICRA.
Yes.
You already know that. So actually, the basic idea was to understand the clinical, because what I have seen in my career of it is only 15 years of, it's not a big career, 15 years practice I'm doing now. So in this small career, I have seen that we clinicians, we lack clinical research in India mainly. जो हमने देखा है, मतलब we have very good clinicians in India, I met, but lacking research. So that is my area of interest. So we wanted to help them understanding the concept of कैसे करेंगे research. For example, आप एक अच्छे osteopath हो, आप एक अच्छे manual therapist हो, but I tell my friends, you can ask on my Facebook or my network, I tell them that I know that you are a very good clinician, but you have to prove to me. That is only when you publish papers with me or with your colleagues. That's very important. So faculty members and clinical researchers, we have this platform for you all, where you can, if you are learned faculty, you can come and join. If you don't know, our faculty is there to mentor you, guide you, to have an understanding of research, designs, and these things. So that's very soon we are going to start the membership and affiliations with different universities and colleges, so that we have this, बोलते ना वो हमने वो हीरे चुने हैं पूरे इंडिया में वर्ल्ड वाइड से, जो रिसर्च जो दे आर प्योर रिसर्चर्स, अंडरस्टूड, academicians like प्रशांत सर है हमारे पास, डॉक्टर many other, Fazan Kashu, मेरे friends हैं, Dr. Neeraj and all. So there are many, Professor Kule from GNU, Sandeep sir. So we have very good panel of researchers. So we welcome all the researchers and faculty who are really interested to share their knowledge and to teach them, because we want a better, हम चाहते हैं कि at least हमारे 10 साल बाद हमने क्या दिया प्रोफेशन को. So we want to have a legacy of these researchers, that देखिए हम अपना काम कर रहे हैं, you are also working, आप प्रकाश भाई पटेल अपने कॉलेज चला रहे हैं, सब अपना काम कर रहे हैं, but what are you going to give to the fraternity? That's very important. So we thought that let's give evidence-based quality research to the people so they understand. अब कल जब आपके बच्चे निकलेंगे, now I'm telling the all students that it is the only research based practice can lead you जहाँ अब जो मैं अभी पढ़ता हूँ, मैं सीखता हूँ, I learn about pain sciences. It is my doctor, PhD मेरा इंटरेस्ट है, फॉर डॉक्टर थीसिस मैं उसमें पढ़ रहा हूँ, काम कर रहा हूँ, बट आई लर्न फ्रॉम डिफरेंट पर्सन अराउंड द वर्ल्ड. मैंने शेयर नहीं किया, एक्चुअली आई लर्न फ्रॉम डिफरेंट फैकल्टीज, फ्रॉम अमेरिका, फ्रॉम जर्मनी, फ्रॉम फ्रांस, स्पेन, फ्रॉम ऑस्ट्रेलिया. सो दे हैव डन लॉट ऑफ वर्क. सो why can't we do analysis from India? हम भी कर सकते हैं. We can also do meta analysis. We can share quality evidence कि भाई इससे ये होता है. So that is only possible when you have a research platform. तो हमने आपके लिए बना दिया है. So you are all welcome to join that later on, and it will be only, I tell you, इसमें हम लोग बोलते ना इसमें हम लोग वो भीड़ नहीं भरेंगे. It will be only open for the professionals जिनको interest है, क्योंकि हम जब membership start करेंगे, it will be in batch wise. We will have only 100 members. उनको पहले mentor करेंगे, उसके बाद we will start others. So it is not like हम लोग कोई एमवे का प्रोडक्ट बेच रहे हैं, नो, we are there to improve your quality of evidence of research. So that is why ICRA was made, and I thank the VN Medical College, Mr. Prakash Patel, Neha, Mule, and everyone, and all the students and faculty who gave me the opportunity. And I hope that anybody has any doubt, we can wrap up that.
Yes, you can reach out to us if you have any doubt. I will definitely forward to the sir, and he will definitely reply. Right? So yes, let's end the session over here. Thank you, sir. Once again, thank you very much.
Okay, thank you. Bye bye, guys. Take care. Bye.
Bye, sir.